Kathleen's accent. I think she does have an accent. Very nice. Well, it's my pleasure to introduce our last presenter this afternoon. We have bookends here. We had Jan at the beginning telling her story without any introduction, purposely. And this afternoon we have Jean Rommes. Jean's a PhD type. She's a researcher. She's one of the most informed, or not, if not the most informed, individuals with COPD that I've ever met. She sits on our Medical and Scientific Advisory Committee and offers really good input as an individual with COPD, as well as a scientific perspective looking at it a little differently. And she also sits on the governing board of our COPD Patient-Powered Research Network. Was a leader, still is a leader at efforts, and very active on the internet, providing counsel through their COPD 360 social platform, and it's just an incredible resource and asset for our community, and it's my pleasure to ask Jean to wrap it up for the day. Thank you.
Can I just turn this thing down so it goes away? Okay, good. That's nice. John, thank you very much for that very nice introduction. And I just lost where I was, so I'm going to have to play around with this a minute. It just went away on me. Come on, there we go. Okay. I really want to thank you for that very nice introduction, John. I was really pleased when I was asked to do this, to do the wrap-up and the takeaways from this first day of the Readmissions Summit. But at the same time, I realized that I was probably asked because I haven't been hospitalized since 2003. Therefore, there's a question in the room as to whether I know anything about readmissions. And do I have anything relevant to say about the topic? Well, I think I do, and here's why. In my professional life, I was the CEO of a not-for-profit company that provided residential and vocational supports for people with disabilities, mostly intellectual disabilities, but also mental health disabilities and physical disabilities as well. My new career as a COPD advocate has plunged me into healthcare issues, specifically those having to do with COPD. But I've just begun to realize that my two worlds, my professional world and my personal COPD world, are beginning to come together. Even the language is beginning to be the same. I was really struck when Dr. Krishnan said this morning, as he was talking about patients with COPD, he was talking about patients with COPD. In my world, we've always talked about people with disabilities, as opposed to the disabled, the retarded, the mentally ill. We've talked about that. So the language is even turning to be the same. And that's pretty exciting. In my professional world, when I first started work, we took care of people. We did for them. About 25 years ago, we realized that what we really needed to do was we needed to teach people what they needed to learn in order to become as independent as possible in their own world, in spite of their disabilities. So we changed from a caretaking profession to a professionals who taught people how to do things for themselves. We thought we were really doing great stuff, except that sometimes people just didn't learn what we wanted them to learn. They didn't seem to care. And about 10 years ago, someone came up with the brilliant idea to ask the people that we worked with what they wanted out of life. What did they want to do? And when we did that, and then we tailored what we knew they needed to learn to what they wanted to be able to do with their lives, lo and behold, they learned a lot. Satisfaction with services went up, stakeholders were happy, payers were happy because we were getting better outcomes. It really worked. We called this person-centered planning. So you can imagine how excited I was to hear people talking this morning about patient-centered planning or family-centered planning, even more inclusive. But patient-centered planning is really kind of what I kind of want to focus on here. And what I've heard today is that what's beginning to happen in our COPD world is a fairly major shift in the way we think about COPD, the way we think about hospitalizations, the way we think about patients and medicine in general. The recommendation from the first summit that patient-centered interventions, rather than disease-specific strategies, are developed, tested, and implemented to improve outcomes important to patients is actually being done. It's being implemented in some of the programs that were described in the breakout group that I was in this afternoon. Dr. Tomashout talked about moving towards patient-centered care as a way to help determine what's important to treat, in which ways, and why. What was wrong with the dynamic of both the caretaking model and teaching model in my professional world was that we as professionals determined what we needed to do for Bob, or what Bob needed to learn to do. And it was only when we started to ask Bob what he wanted to be able to do that the dynamic began to change. And it was because Bob was now the center of our discussion and part of the discussion, not his diagnosis, not his deficits, although we've been very quick to point them all out to him on a very regular basis, but what he wanted was what was important all of a sudden. When we talk about this now, in my world, whether we're talking about funding, programs, training modules, anything, we say, remember, it's all about Bob. Bob is the most important person in the equation, whether he's in the room or not, and most of the time, he's there now. He's a player, and he's at the table. And as a patient, I need to be a player, and I need to be at the table. And that's what I'm beginning to hear today, is that I have that opportunity, and I'm not going to have to fight for it quite as hard as I have before. That's the best part. The conclusion of the first summit said, interventions to improve outcomes need to be tailored to the setting in which it is to be applied. Community building and patient voice is needed to ensure that patient-centered interventions are developed, tested, and implemented to improve important outcomes that are important to patients. What's emerged in this conversation today, I believe, is the recognition that my COPD is way more than just my disease state, and that to treat it effectively, we're going to have to engage all sorts of systems, including the medical one, but most importantly, we're going to have to engage me, where I am, and my knowledge of my disease and where I am in the social network. If I'm homeless, we're going to have to engage the folks who work with the homeless populations. The National Centers for the Homeless is one of the leading organizations, lists all kinds of resources. I looked them up online last night. But we're going to need to engage them for those homeless people. If I don't use my inhalers, we need to find out whether it's because it's a problem of not knowing how to use them, a problem of not being able to afford them, simply being forgetful, or maybe I have Alzheimer's, or just being stubborn because I don't want to, or any combination thereof. I get many of my medications from India, because for what I pay for one copay for Advair from my local Walmart, I can get 6 Advair discs made by GSK in the UK and marketed in India. We need to address the issues of my family, my friends, my state of mind, my financial situation, all of which can influence how or even if I respond to treatment. Dr. Tomashow touched on all those issues in his presentation, and Dr. Frommer elaborated on them all in his discussion of the various teams and how the teams need to communicate and coordinate. I particularly appreciated his last slide with an informed, active patient on one side and a prepared, proactive practice team on the other side, and productive interactions between them. The first summit concluded, an infrastructure to promote and sustain collaborations between patients, caregivers, providers, payers, researchers, and other stakeholders is needed to identify strategies of care needed to improve post-discharge outcomes in patients hospitalized for COPD exacerbations. I think, again, we're beginning to see some of those collaborations be developed from Dr. Frommer's task grid as a wonderful example of how his office is taking the responsibility of establishing that communication with the team and with the person, with the patient. We've learned today about some programs that actually work with patients around what they want to achieve and then help them find the tools and resources that help them achieve that. There are so many things that patients need to learn, and it really is overwhelming. So we need to remember the lessons from my professional world experience. I will learn faster and much more efficiently if we associate what I need to learn with the goals I have set for myself. And these programs do that. Some of the programs we've heard about have utilized public health system, case managers, respiratory therapists, pulmonary rehabilitation programs, nurses, all those folks. Most of those programs have been facility-based. Some are outreach via phone or in personal visits. Most of them have demonstrated some measure of success. One of the problems is that there are so few programs and fewer funding sources for them, as you all probably know better than I do. Some programs are using patients in patient education, helping to increase the health literacy and specifically the COPD literacy among the COPD patient population. Connectivity is a huge issue, and finding out who's responsible for initiating and maintaining connectivity with patients, with caregivers, primary care physicians, pulmonologists, all the various social services, and all the other players in the system that we probably haven't even identified. Establishing this system and then maintaining it is a huge issue. But we've seen some programs that have actually created systems that work, that have begun to do these kinds of things. Now we have to figure out how to sustain them in the systems we have and build more and more of them so that it doesn't matter whether you're in New York City, Chicago, Los Angeles, Creston, Iowa, Ionia, Michigan, or small town anywhere. You get those kinds of services. The goal to keep people out of hospitals is a great one. And believe me, I'm all for that. The takeaway from this, for me, and I hope for you, is that we continue to move forwards with this patient-centered approach and find a way to reach a point where Jean Rommes in West Des Moines, Iowa, a COPD patient, can be assured that she will be the center of the treatment plan and the treatment team, where what she wants is known by everyone on that team, and where she gets that kind of treatment and approach, not because she's assertive, knowledgeable, and willing to take on docs and other health professionals, but because every health professional she knows understands and operates by that standard. Thanks for letting me come, and have a great evening.
Peter just leaned over to me and said, "Boy, you got a ringer for the final here." Wrap it up. So, thank you very much, Jean. We really appreciate your comments, observations, and counsel. This wraps up our day, and I think it's been a full day for everybody. We have a reception at the Liaison Hotel right down the street. So you go out the front door, go left. Most of you came the other direction this morning. Go left down to the end of the street and take a left, and Liaison Hotel's 2 blocks over on the left-hand side. So left, and Liaison Hotel's on the left, 2 blocks up. And we're going to have just a networking opportunity tonight and be able to reconvene right away in the morning. We really appreciate, again, everybody making time to make this happen and fully appreciating how important it's going to be for all of us to continue to work together and cross-fertilize moving forward. So thank you very much, and we'll see you. Enjoy the evening, as Jean said, and we'll see you in the morning. Take care.